Good day and welcome to our session today. Our sharing session is made possible given the funding support from the Gates Foundation to ASLM and partners. My name is Francis Ochen from the African Society for Laboratory Medicine, and I'm your moderator for today's session. This session will run for 1 hour. We'll have a 40 minutes presentation and then spare about 15 minutes for questions and answers. Keep your questions coming through the chat in either English, French, or Portuguese. We have simultaneous language interpretation services, so feel free to post in your question in any of the 3 languages, and we'll be able to deal with those that we can help deal with during the session. Our session slides and recordings will be made available to you as soon as they become available. In today's session, colleagues, we focus on the progress in foreign assistance space, the past, now, and predicting the future. Of course, based on what we currently know. And we also know that predictions are as good as the assumptions that go in them, and also the validity of the elements that feed the assumptions. We are aware that foreign assistance supports really recipient countries with their economic growth. It strengthens social programs. It helps with response to crisis and protects communities around the world. And the scope of the assistance has been changing, evolving over years, with some facets directed at addressing global health crisis and disaster situations, either preemptively or as a response package. And in today's session, we will cover the history of PEPFAR and other general funding programs, the impact, and also discuss national level potential mitigation strategies that can deal with the short term and then the long term, given the drastic reduction in the funding that we're seeing. And to take us through this, we have a distinguished speaker. Our speaker today is Professor Francois Vanta. And Professor Vanta is the Executive Director of the Edinshire at the Faculty of Health Sciences, University of Witwatersrand in Johannesburg, South Africa. Professor Vanta has been involved in HIV programming from 2001. And he actually ran several large PEPFAR programs till 2012. And so colleagues, join me in welcoming our speaker for the day, and Professor Vanta, over to you.
Thank you, everybody. It's really wonderful to be able to talk to you, although I wish it was in better circumstances. I'm going to sketch PEPFAR and what I think is going to happen here and what has happened. Should creatively together, and I think particularly ASLM in terms of taking things forward. I apologize for one thing. My program, my presentation does tend to focus on South Africa, mainly because that's what I know best. It is also the place where a lot of data is available on what's happened in the last few months that I've had access to. So I can show you some of the stuff. I am in contact with lots of my clinical and program colleagues in other countries, so I can tell you what's happened. It's not up to the minute correct because things are changing so quickly. I think any of us who've been watching the news just the last week, feel a bit swept off our feet because it just changes all the time. But I'm fairly up to date, and whatever I've got, I'm going to give you, and hopefully you can update me during the question and answer time if I get things wrong. So just with those caveats, let's go and let me show you what's happening here. And I do think this is a catastrophe. I think that certainly for the sub-Saharan, for African countries depend on PEPFAR, this stuff is not good news. These are my various disclosures. As Francis mentioned, I did run a very large PEPFAR program till 2012, and I've been on various advisory groups within the PEPFAR programs in South Africa ever since then. So it's been a tragic phase. The Trump administration came in, and within a very short period, within days, he shut down. He put in this 90-day stop order, and it's led to these multiple programs, not just PEPFAR, but I'll show you in a moment a whole range of other programs that have been stopped. And various people I know, and many of you know, losing their jobs over the last few months. And just in the last week, people I know who've lost their jobs in the US and locally. So it's been devastating. I think that for those of you who've been watching this closely, I think pretty much everybody on this call pretty much has. It's been the subject of a huge amount of horror to watch things being stopped and dismantled so quickly. And it's important to remember that the funding cuts went way beyond HIV, TB, and even health, and that entire health systems were dependent on funding. Places like Malawi, Zimbabwe, 70, 80, 90% of the funding for the health system, not just for HIV, TB, was dependent on American government funding through different mechanisms. And it's important to recognize that. And while some of that funding may have returned or may return, it looks at how dependent many of our countries are on US government funding. And it's not just those countries. A place like South Africa is dependent in a very different way. But USAID was very, very instrumental in the whole range of famine and disaster relief in a way that I certainly wasn't aware of till this funding was stopped. And the whole places which were experiencing famine and food interruptions for whatever reason, have had those food interruptions recommenced because USAID funding was stopped. So people are starving to death simply for lack of US government funding. And it's also important, again, many people on this call will not need to be reminded of this, is a lot of the research budgets have been hit because of both USAID, but also NIH research. And for instance, in Sub-Saharan Africa, a massive percentage of our research budgets come from NIH and from various similar budgets. And then there's all the other stuff, which I was surprised how much money USAID was giving across to things like governance, climate change, vaccines, to the Food and Drug Administration, to CDC advice, these websites that I routinely would go to look for advice on where it's safe to go, what the malaria resistance patterns are, where Ebola is this week, those kind of things I rely on heavily. Suddenly, a lot of that stuff is being either stopped or paused, or in some cases with the mRNA vaccines, just removed from the CDC website. And things like air travel safety, pandemic surveillance. You guys know this stuff, but it's just, we're so dependent on that US money. Now, the responses have spanned extremes, and people have come back with all of this stuff. And there's an element of truth in all of this. You'll see it from politicians, you'll see it from media commentators, you'll see it from our own people, even from academics, and they'll say, Americans should not be blackmailing us like this. It's time we must stand on our own 2 feet. Africa must look after Africans. And you'll see some of that even in the academic articles that come out. Now, that's all too well. It's, when you've got 2, 3, 5, 10 years to plan. It's not okay when your clinics are shut literally overnight. There's no time for planning. And this reminds me of a lot of the rhetoric that came out over COVID, including from my government, who said, it's time we stood on our own 2 feet about vaccines. And then the minute, the vaccines the prices were put out, we eventually went straight back to India and bought them there. So it's one thing, our politicians say one thing, but they mean something completely different when the rubber hits the road. So it's, this kind of language doesn't impress me anymore. It sounds very tough, but it doesn't actually bear out when the rubber hits the road. And people say things like HIV gets too much anyway. It's time we got things back to where they were. And, that doesn't make sense when people are dying of HIV. And certainly in my country, HIV gets them, still doesn't get the money that actually is disproportionately less than the disease actually warrants. So this is like one of these meaningless statements that makes people feel better about themselves. People talk about the Treasury and the private sector must fund the PEPFAR program. They must step up. Well, it's a lot of money that governments must come and find at the drop of a hat. And particularly for poor countries, it's very difficult to find that kind of money. We must strengthen the health systems and integrate HIV. People have been saying that since the first day of the PEPFAR program I was involved in. And my response to them is, why haven't you done it already? It's so easy. Why didn't you do this? And it's frustrating for me to hear these kind of statements coming out of people's mouths. It just makes you feel better, and it's actually quite lazy. The reason we haven't done it is it's actually hard, and part of the reason is HIV is actually being very efficient. And then the final thing is, we'll be okay. And I hear this often in South Africa, it's going to be fine, it's going to be fine. And maybe that makes you feel better. It's not going to be fine. And I'm sorry to do this. I keep being told this is a very pressing and talk politics very time that we have successfully exported. And I'm ashamed to say that this has come from there. It does say my internet connection is unstable, so I'm hoping that you're hearing me. It says it's back online, so I'm hoping I'm back. So how do we get here? And it's important to remind ourselves when we get bleak and we think, oh my goodness, with the other extreme, which is to throw up your hands and say we're all going to die and everything's going to be terrible, is we made amazing changes in the HIV. And some of you are probably old enough to remember the HIV story from the very beginning when we started in the early 2000s. And this endocrinologist at my university said this to me in 2023, said, treating diabetes is hard, treating HIV is easy. And he's actually right. When he came up to me, he's like, I can't dispute this. You start, this year, before this started, you come in with HIV, you get diagnosed, you get given your tablet on the same day, you go home and you get better. We do some blood tests, but you come back for those blood test results, but you don't wait. You just get your tablets, you get started, you get better. And these tablets are cheap. They are very, very safe. But that was not the case in 2003 when we started. In those days, we started with D4T, we started with 3TC, we started with nevirapine and efavirenz. You got different doses if you were 60 kilograms or above or below. If you're a woman of childbearing potential, you start with nevirapine. If you were not, you start with efavirenz. We even dose adjusted efavirenz if you had TB. We had one tablet for every single drug. There were no fixed dose combinations. And if you stopped your drugs, you had to cover the tail with all these combinations and things. And we had CD4 counts. Even to get a diagnosis of HIV, you had to have multiple blood tests. You had to have confirmation. We didn't have point of care blood tests at the start. So when people tell me how easy it is now, yes, but we worked hard to make it easy. And there are lots of problems we had to solve in the last 20 years and last 25 years. So give us some credit for the hard work that you guys and people like me and others have done to make it easy. But unfortunately, a lot of that work has been undone with the current things. Now, a short history of PEPFAR, and that's the very first PEPFAR ambassador opening up one of the HIV clinics in the hospital in Durban at the opening when I was there in 2004, 2005. And it was first announced by President Bush, a very conservative president, one of the Republicans, part of Donald Trump's party in 2003, came up with the idea. So this is not some left-wing, bleeding liberal program. And one of the things that's been interesting about PEPFAR is it's enjoyed bipartisan support. So from across the various political people in America, this is not something that's contested from the left and from the right. It's people have recognized, whatever your political persuasion, of its importance. It's been implemented in 50 countries. I think if I remember correctly, it was initially about 8 or 10, and then expanded steadily as people appreciated how important, how successful it was. Initially, it was $15 billion, and then it went up to 100. It's been 110 billion in total. And it's the largest commitment to any single disease by any nation ever. So it's not insignificant. So when our countries say, oh, we'll pick up the slack, we'll find it for our national fiscus, for a country as poor as many of our countries, it's impossible for them to just simply magic up this money out of nowhere. This was a massive commitment by one of the richest countries in the world. So it's not as if somebody's going to come in and just replace this money overnight. One of the things, those of you who've been in the PEPFAR program will know this, but they only do HIV. I remember this guy, this Randall Tobias, standing up and he said, the health problems are this big. HIV is this big, PEPFAR is this big. We are going to just do as much as we can. And one of the, and then with it's come solving the HIV programs in a very focused way. So in places like Malawi, for instance, and they pay for everything. They pay for the drugs, they pay for the labs, they pay for the nurses' time, they pay for the doctor's time. In a place like South Africa, they pay for discrete areas. So in South Africa, we pay for our own drugs, we pay for our own labs. The nurses, by and large, are paid for by governments and their salaries. But PEPFAR does the intelligent work of plugging the gaps in between. And all the countries in the region have variations on this, somewhere in between. And some pay for their data systems, some pay for their supply systems. So having been in the PEPFAR program and being an advisor on the PEPFAR program, I have my criticism of PEPFAR, but it brings both the best and the worst of the Americans to us. They are completely focused on productivity. I remember one senior PEPFAR person when I was running the program saying to me, I was complaining about how hard my life was. And he said, I pay you for solutions, not for problems. And that really gets to the heart of what PEPFAR was about. It was like, We pay you to get so many people on treatment, to do so many tests, to move those people into treatment. We pay you to keep so many people in treatment. They weren't interested in excuses. And they would say to you, if you keep these people on treatment, you'll keep your program, you'll keep your money, you can keep your staff. And if you don't, we'll go to the NGO down the road who are quite happy to take your money. So don't come in with your excuses, just get on with the job. And it's a horrible place to work being in the PEPFAR program, but it really got the job done. And people would be very critical and say, what about hypertension? What about vaccines? What about clean water? What about poverty? And PEPFAR people would say, I'm not interested. You go and solve those problems in your own time. We're here for HIV and HIV only. And that sounds terrible, but when I think about it, it got the job done. HIV got solved and got solved well. These other problems, they're still not solved. And for all the people who told us we must solve everything, nothing else has been solved in the meantime. So it's an interesting thing to be thinking about how to solve other problems when we talk about these things. This is the propaganda, and I'm not going to bore you with talking about them. You can go get these numbers off the website. You can go to the PEPFAR website. But it's been an incredible public health success. If you measure numbers of people's lives saved, people's lives, dragged back from the brink, families put back together again, societies put back together again, it's been incredible. And it's been very good because they focused directly on the most affected communities. Where HIV wasn't, they left those places alone. They went, so for instance, in South Africa, they went to the 27 districts where HIV was the most prevalent, where 80% of people with HIV were, and they just focused there, laser-like. And they went and they said, we're going to go and find the people there. We're not going to go to the very rural areas where people are scattered across very big areas where there's actually not that much HIV. We're going to go where the epidemic is. You must remember in my country, as in many places in the region, it was devastating. In 2003, when I was a junior doctor, we would just step over the bodies in the hospital. There was about 20 deaths a day just in the big hospital I was working at. People just died on the floor. It was horrible. And the interesting thing is that there were a lot of activists in South Africa and fighting for HIV treatment against our government at that stage was in a terrible denialist phase. But when PEPFAR fell apart, many of these people stepped forward, not just in South Africa, but across the world. All these people I knew at the time, who kind of disappeared in the last 20 years because HIV was steadily being solved, have stepped back again and have been starting to fight back to get the money back, to try and fight for some sort of system to allow for relief from having the PEPFAR disruption taken away. So I'm giving South Africa as an example because this was the program I was involved in. It varied from country to country, as I said, dramatically. What you get in Mozambique was very different from Zimbabwe. Botswana, Lesotho, South Africa, I think were very similar. So initially, when I came into the program in 2004, 2009, there was this massive hospitalization crisis. The hospitals were just overran. And that's where we really were grappling. And it's because we had to slowly pivot to case finding, going into the communities, going to find the key populations, the sex workers, the gay men, the trans populations. And we also had to simplify the program, so all those D4T and 3T and those the CD4 count thresholds and things, we had to keep simplifying the program to get it into primary care and away from the hospitals. But at the time, the CD4 count was 80. You remember, and that at 80, so many terrible things happened. At the last time I looked, which was 2 or 3 years ago, our average CD4 count in South Africa was about 400. Now, most people at 400 are completely healthy. There's nothing wrong with them much. They might have a little bit of thrush at worst or a little bit of a dry skin, but very few people are sick at a CD4 count 400. At 80, people are very sick, and they often have terrible sicknesses that need specialists available to look after them. So by moving them into an earlier diagnosis phase, you get away from the hospitalization. Antenatal transmission went right down from about 70,000 a year down to 2,000. Antenatal transmission in South Africa is actually quite rare. Our new infection rate went right down in 20 years from 500,000 a year to about 130. Some people say it's a little bit higher than that, to 130,000. So massive decrease in new infection rates. And it varied in other countries, but certainly in Zimbabwe, Swaziland, Lesotho, Botswana, Namibia, all the countries around us, we saw dramatic drops in new infections and drops in death rates and all the rest of it. So even though the epidemic looked slightly different from country to country, PEPFAR was making an impact across all of this. And a lot of my work was was characterizing side effects, trying to get people into care, working out which CD4 count, which drugs, what doses, all that stuff. And trying to work with lots of very smart Americans, actually, and South Africans, and actually Africans. We had really amazing collaborations across the region to try and find better ways of doing things. And I didn't really think about myself as a researcher. I was thinking about how do we save as many people as possible, which I think many of you were probably in the thick of it as well. And then in 2000, South Africa's government changed in 2008 when Jacob Zuma took power and swept away a lot of the nonsense that we were dealing with HIV inside the country. And we started making real progress. And in many ways, the HIV program almost took care of itself. We managed to move things into primary care, got case finding, and we started making fantastic progress in terms of lots of things. Now, it certainly was far from perfect, but we didn't have the problems that we had. And certainly in South Africa, we now have 6 million people on state-of-the-art therapy out of the 8 million people on infections. And many of you have heard of dolutegravir, which is a lot of the work I was doing at the time, which has been an absolute massive boon to the whole area. It's replaced efavirenz. It had better side effects, better persistence. It's incredible from a resistance perspective. We've only got a handful of resistance cases at the moment, and it was much cheaper than the efavirenz-based regimen. So it's not often in medicine you get something that's better and smarter and cheaper. And it's been a massive public health success. So for all of us, we've seen our HIV programs get better and better and better. And then January the 20th came when the 90-day stop orders came and the whole thing came crashing down. I chaired this session at CROI, the big HIV conference in San Francisco a few weeks ago. And there were people from Kenya, from Zambia, from Zimbabwe, from Malawi, and they were all talked about their different experiences of the PEPFAR collapse. And it was interesting how varied it was, but they all were devastating. So in almost everything in terms of testing, HIV testing had stopped almost in every country, including in South Africa. And the PrEP programs, the prevention programs had ceased. So the one thing that was common across every single country was testing and prevention had stopped. So that certainly in South Africa has persisted, and from the sounds of it has persisted in almost every other country as well. There were incredible supply line issues, and that varied quite dramatically. But say in a place like Botswana, they were monitoring their supply lines, and Uganda was another case where they just didn't know where their stock was. So the TLD stock, which had been monitored by PEPFAR supported systems, those people just didn't come to work, or the systems were electronic and locked down. Suddenly no one knew where the drugs were. They were at the pharmacy, at the depots in between, or in the clinics. So those systems just came crashing down. And certainly in South Africa, we have now got reports of stockouts from across the country of people not getting their drugs. In Kenya, I was told that the electronic medical records were shut down, and that the linkages from the labs to the electronic medical records was shut down also again overnight. So no one knew, the patient would walk into the clinic and no one would knew where that patient stood, what they were on. Luckily, TLD was what everyone was on, but they wouldn't know what their blood results were, what their medical record showed. And the same went for Uganda, but this was more tied into the stockouts that made life very, very difficult. In Malawi, Uganda, Zimbabwe, where the health force was entirely funded by PEPFAR, no one was able to come to work, so there's no one to dish out the drugs, no one to examine the patients, no one to write the prescriptions. So again, complete stoppage of the programs. One of the things that was shocking to me was one of the Zimbabwean representatives talked about the health tax, which has been levied, I think it was 3% of all payroll. He said that, that everybody not being paid anymore, that 30% of the health tax had not been collected. And this goes to AIDS procurement within Zimbabwe, which suggests a massive number of salaries within Zimbabwe are being supported by the US government. And there was this terrible question asked of the panelists by somebody in the audience, said, if you had to cut stuff, what would you cut? If PEPFAR is not coming back, what are we going to need to get rid of? And there was this very awkward silence during the thing. And this report, which you can get online, just Google the headline, and from the Clinton Health Access Initiative, shows this devastation across many countries at different levels, whether it's monitoring, whether it's treatment, whether it's prevention, whether it's the testing program. And the area I'm particularly interested in, which is obviously adult treatment, which is where I've been looking at. And you can see, I'm not going to read it to you, but you can see the devastation across these areas. WHO has been doing rapid country assessments across 108 countries, again, showing multiple things. Again, this slide deck, you can just Google it and it's available to you. It's freely available. This one slide really caught my eye, and they showed that just something for our governments to think about. My own government, which doesn't seem to be taking this problem at all seriously, said that the extent of the damage on average was 75% of what COVID did. So in the first 3 months of the stoppage of PEPFAR is about the equivalent of 75%, three-quarters of what the disruption level that COVID caused. So we made such a fuss throughout the world about COVID, and yet there's hardly the same level, certainly in South Africa, not the same level of fuss around this disruption, around the HIV disruption. So it's just told you how terrible what's happening is in the background, and how ministries of health some ministries of health seem to be reacting with urgency, but others like mine just don't seem to think it's that much of a problem. This article came out yesterday, which shows that it's also not just on HIV, but also the impact on TB services. And this specifically looked at South Africa. I can only imagine it's similar in many other African countries, but just showing the devastation in terms of testing and moving people into care services within the TB services. So again, South Africa's TB services have shown steady improvement over the last 20 years. That's probably going to all be reversed over the next while unless we fix things. And this was just one of the graphics from the paper that just showed the Aurum Institute, which is implementing one of the USAID programs, just how much work they were doing out in the community, varying everything from the outreach programs to case tracing, just to active screening with chest X-rays. And you can see just how much work they were up to. So when I chaired that session in San Francisco, this guy from Zimbabwe, it was amazing. Honestly, I think I wish he'd come around the South African program. Said to me, he said to the audience, he said, the African ministries of health said, we've got this. This is the wake-up call we all need, but don't worry, we've got this. We'll try our best to make what we can do. We'll try and find it. We haven't got as much money, but we've got this. And he said to us, we knew we didn't have this. We didn't have the resources. We didn't have the expertise. We couldn't pick up such a huge burden so quickly. But what else were we going to say? Everyone would panic. And we're the government. We can't be seen to be not having this. We're in charge. And my frustration with my own government is that they're saying this often with, and they actually don't have this. They think they do have it because we actually have a functional healthcare system. Unfortunately, I'll show you in a moment, the things that we're not good at within any health system, which is case finding, is this thing that the South Africans don't understand that they should be doing. So firstly, the money. And as I showed, there's no donor, with the possible exception of the EU, that can match PEPFAR funding. And unfortunately, the EU is busy fighting a war in the Ukraine by proxy. And it's most low-income countries, we could probably put all the African countries together, and they wouldn't even come close to matching the amount of money that's required. So this is not really. South Africa, Botswana, and Namibia largely fund their own programs, but those key aspects I'm going to get to in a moment, they don't fund those and not good at running those kind of programs. For the rest of the countries, they've often talked about integration. So these people must go back to the facilities. They must go back and see the doctors and nurses in those facilities. The problem is in places like Zimbabwe and Malawi, many of those countries at different parts of the geography, depending where the geography is, the level of those programs and the availability of those clinics is very, very limited. So it's not as if in South Africa, if you say integration, people can go to a primary healthcare clinic. Same in Botswana, the same in Namibia. It starts varying in the other African countries. And in some places, there is no functional clinic. So there's no integration. The thing you're integrating into is very, very limited. So it's not as if it's as easy as simply saying, go to the local clinic. It may not be as good as what you used to, but if there's something there, sometimes there isn't anything there. Or the thing that's there is so hopelessly overloaded that nurse or that healthcare worker is not able to just simply take on the burden of several new 100 patients coming in through the system. And this shows you, if you come off to the right, I'm going to try and move I'm not sure if you got my face in front of you, but if you go to the right there and you look at those lines, you can see how dependent some of these healthcare systems are on donor funding. You can see South Africa, which is not that dependent on donor funding, and you can see the thing there, that dark blue, which says domestic funding, and you can see South Africa is in quite a powerful space in terms of its AIDS program. It's only about 17% of the budget actually comes from donor funding. But if you go across to Zimbabwe, you'll see there that it's largely PEPFAR support, that yellow bar and the red bar at the top, and the rest, that light blue bar, is other international spending. So it's almost entirely dependent on international support. It gets almost no support from its own fiscus. So for Zimbabwe, this has been absolutely catastrophic in terms of what's going to happen. If you come off to the right, to the left, you can see places like Cote d'Ivoire and Eswatini. Better position. Kenya is much stronger, also lots of domestic position, but still very heavily dependent on the PEPFAR program. And then what happened, all the modelers came out of the woodwork. This was actually published in the Lancet last week. And as you'd expect, when PEPFAR funding stops, new infections go up and death rates start going up. So there's no surprises here for you guys. But these modelers were able to demonstrate that we were doing really, really well. And all of that's going to be reversed very quickly if we discontinue and go back to where we were. And JIS, Brooke Nichols and her team, who have an office here in Johannesburg and operate out of Boston University, were able to demonstrate some of this. There have been other articles demonstrating the numbers and just how quickly people are going to start dying. So in America, some very brave activists and people within America have launched lawsuit after lawsuit after lawsuit against the White House administration, saying what you're doing is illegal, what you're doing is wrong. We need you to unfreeze the funding. Now, it's, as I said, it's very brave. I really salute these people. The problem is when you're an African NGO executing PEPFAR funding, you can't take on the risk. When you can't take the word of somebody sitting in Washington, no matter how friendly they are, to say, don't worry, you can spend money. Because if the US government comes back and says, no, that was illegal, you have to give that money back. And those of us who work in PEPFAR know how rigid and how strict those laws are. So you will just be destroyed, immediately with a week's worth of back funding if that comes back at you. So what happened is that until you get written in wet ink that your money is coming, you do not believe things until you see that. So you have to abide by the restrictions until you see something formal. And the problem is they fired everybody at USAID. They all went home, leaving the most skeletons of staff left behind to try and explain all of this. So I'm going to use South Africa as a test case just to show you what they did fund. And as I said to you, they funded 17% of the budget, but not the drugs, not the labs, and also not the staff. And they went directly to where almost 80% of the people live, those 27 districts I was telling you about. And they went and they hunted down people. They would go into the queues, they would go into antenatal clinics, they would test everyone in front of them, and then they would shepherd them into HIV programs to show them where to try and get them in as quickly as possible. And that's why they got the C4 counts up, is they go and find people who are healthy. At the same time, they're doing all this TB screening support I was telling you about. And they also managed the data system. So they collected so much data and managed those systems. So we knew exactly where these people were all the time in real time. And they also gave lots and lots of technical support to the National Department of Health. And they supported all the key populations. So all the sex worker programs, the support to LGBTI players, to drug users, all of this was being run by the PEPFAR people. They also did community monitoring of clinic service quality. So you funded civil society to go into the clinics and ask them, are the staff friendly? Are they doing their jobs? Where the drugs stock out? So all of this stuff. In other countries, it varied. But as I said, it collapsed in different ways. There are some signs that some of the funding was continued, but it seems like it's with caveats that it might be shut down. So I don't know what's going to happen. It seems I was going through the PEPFAR site to see which countries were doing what. It seems like all the key populations are still gone. There's no PrEP except for pregnant women and no prevention outside the ABCs that's been reconsidered. So South Africa often says, oh, it's okay, we've got this. It's not like other African countries. The problem is that South Africa, because there's no HIV testing and the key population programs are stopped, our C4 counts are going to start dropping back to 80. And there are already reports of stockouts. And in the next few months, I think we're going to go back to 2004, 2005 with the mass hospitalization programs coming back again. It also means no prevention, and therefore new infections are going to start going up again. And with no monitoring systems, the Department of Health is not going to know about this because there's no early warning system for them to know. They're going to find only when the hospitals start being overrun. There's a massive impact on the economy. We've lost 24,000 jobs in South Africa alone and 20 billion rands a year just on PEPFAR. There's a couple of billion rands just on research from NIH and everything else. And the other problem for South Africa and the problem for our neighbors is that the impact on jobs in places like Zimbabwe and Malawi is that people are going to come here for economic opportunities. And South Africans, are very xenophobic, and that's always the opportunity for violence. We've already seen Lesotho's program collapse in places almost within 2 or 3 weeks. The minister was trying to put on a brave face and trying his best to try and solicit money, but it's difficult, because Lesotho is very, very poor. In Zimbabwe, as I said, the national AIDS levy was paying for 50% of their ARVs, has now gone. And again, massive impact on their economy. And South Africa just won't engage. The Ministry of Health says, there's been civil societies repeatedly asked them to engage, and they just don't. And the worst part is we've got new drugs coming that were so powerful. They were the vaccine that we needed. This drug, lenacapavir, they've just found an annual intramuscular injection, which we think we can take to 2-yearly. It was published at the conference in San Francisco. If we were able to cover people with TLD and give high-risk populations this injection every 2 years, I think we could have broken the back of the epidemic in the next 3 or 4 years. We were this close to actually getting on top of this epidemic. But we have to pick ourselves off the floor, and we have to try and preserve the HIV response. And we've got to ask ourselves, is this the only way we were able to provide the service? And we have to get our creative hats on, because I think the world has now changed fundamentally, and we have to keep cutting costs. We have to ask ourselves, can we do things more efficiently? And I know efficiency, thanks to Elon Musk, has become a dirty word, but we do need to say, can we do things differently? And can we get drugs into people's mouths in a way that is better than the way we have done in the past? And I think that we're going to have to do it differently in different countries, because each country's got its own different way of doing things and there's different resources. So I think once we picked ourselves off the floor, there is the room for creative thinking. And one of the things, this paper that came out in The Lancet just last week demonstrated that when you invest, when donors do invest, and I didn't actually recognize this until recently, do invest in a country, their own countries start investing in the healthcare system. And this Michelle Sidibe's paper came out with a whole lot of famous people showing that in countries where PEPFAR went, the local government was putting more and more money into its own domestic programs. So there is lessons here for donors that investing in health systems actually is a good thing. But I think we need to anticipate, if we're not going to do this and don't think creatively, we have seen, this also was in the same Lancet, and I'd actually had stopped thinking about orphans for so many years, for over a decade, and suddenly projecting how many orphans we're going to have if we don't get this right. And it's a terrible thing to start thinking about AIDS orphans all over again. So one of the things we try to think about is, can we perhaps drop the dose of this line item? And we do know that if we dose that, say, 4 days a week, 5 days a week, 3 days a week, we might be able to preserve the stockpile. I know I'm in my last few minutes. And there were some studies which have suggested that we can do that. And we're looking at different strategies. We're looking at, can we drop those doses? And Andy Hill has done this meta-analysis in the emergency, say, can we start looking at studies to show, can we do this quickly? Can we quickly show that it's safe to start dropping this? Please don't do this at home yet. We need to show it's safe. But could we maybe get the doses down so that we can at least preserve the emergency stocks that we are doing? Interestingly enough, we've been thinking about doing this in the rich countries because their drugs are just so damned expensive. The other thing is there are weekly dosing of drugs coming along. I suspect this is only going to be available in 3 years' time. But even the cost of current TLD, we can possibly bring down by going to weekly drug doses with these new drugs like lenacapavir and islatravir. And the preliminary data looks very, very strong. And instead of giving 28 tablets a month, we can give 28 tablets every 6 months. So it stops a lot of the other things. And the cost of that might be very, very, very low. But as I said, it's going to take a couple of years. So it's not going to bail us out of this current problem. And can we test people differently? Can we give self-tests? Brooke Nichols, again, the person who did the modeling, was going into clinics and handing out self-tests to people. So taking out the counselors and taking out a whole lot of the linkage systems and things, and showed that if you just go into a clinic or into a taxi rank and handing out self-tests, suddenly new initiations went up. So cutting out a whole lot of the systems. Now, while self-tests are more expensive than conventional tests, maybe in places like South Africa, that might be a better way of doing things. Some of them might be reinitiations. Some of them might be new initiations, but do we care? We just get more people into care. And maybe we need incentives in some of the countries. Maybe we can move people into and start to think, as I said, just creatively about these things. And maybe we can deliver services to keep populations more efficiently. Do they have to come to a clinic? Can we have just better websites? Even in the poorest parts of Africa, now we have the internet. It's just, can we do these things? We're doing the same thing for over 15 years in the same way. We just might need to be doing things more efficiently. And recognizing that PrEP is an ideal thing that has been an absolute disaster in terms of getting care out there. One of the things that alarmed me from the conference in San Francisco is how absolutely dependent PrEP programs are on PEPFAR. Almost everything across the globe, not just in Africa, is dependent on PEPFAR. Almost nothing is paid for by anybody else, including government programs. So can we just do this differently? Sorry, I seem to have... So my conclusion is that this is a dreadful, dreadful situation for everyone, for the patients, for the healthcare workers, for government officials, for researchers, and it's across the world. In America at the moment, I see people from Harvard are having their grants cut today. So I think we need to have empathy for everybody concerned and some patience, but we do need to move quickly to try and shore up our AIDS response. It's a terrible situation for everyone concerned, but it's going to need maximum creativity. I think we need to hope that some PEPFAR will come back. There are some signs it might come back, but we need to prepare for the worst. And if it doesn't come back, we can't sit back and wait and hope. Things are going to need to change across each one of our countries in terms of how we do things. And finally, we do need to maximize our creativity, our collaborations, and our empathy across this region to try and help each other as much as we can and share these ideas and move as quickly as we can to support each other to get our HIV response back on track. Thanks, everybody. And this is my team who do all the work while I just walk around giving lectures. So I hope I didn't hurt the translators by going too fast. And I hope I didn't go too far over time, Francis.
Excellent, excellent, Professor Vanta. Very expertly put there. What a session. And really a great testament to the far we've come, far from far, and making sure that HIV care, treatment, diagnosis is simplified. But the risk that this might, the tools we currently have, the biomedical tools, might actually be taken back to the toolbox and will not have the capacity to use them anymore.
Beautifully put.
Then the aspect of also the differential impact that the funding cuts are having on different countries, given the creative funding approach that PEPFAR was taking. And so one country, the way they're being impacted might not necessarily be the same as the other country. Of course, there could be groups that are impacted in a similar way. And then the last bit, and of course, among many things, is the creative approach that we need to come up with to make care and prevention more efficient. Some of the biomedical interventions that should come up, bi-weekly dosing or testing for viral load, not necessarily annually, but depending on what data we have and where data will be leading us. So very expertly put there. I can't summarize everything. We have a few questions, and colleagues, please, the questions coming through the Q&A space, and we'll try as much to deal with all of them. Prof, we may start with one from Wesonga, and Wesonga is asking, and he starts by saying that funding has affected HIV in KEMRI is an institution in Kenya, and also the other community-based organizations therein. And it is making research courses less lucrative and maybe attractive. So in your thinking, what can Africa do to try and make the future of our funding, but also research-based programs more appealing?
Yeah, one of my frustrations with African governments is we complain a lot. We don't do anything to actually directly make it more, the word isn't lucrative, just happier to stay in our countries. One of the things that's going to be much harder now is to find a research career in America or Europe. While I was in America for the San Francisco conference, it's the first time ever I've had people from Yale and Harvard ask me for jobs because they're just losing their jobs. So you're not going to be emigrating for a better life for a research career elsewhere. In fact, a lot of Africans there were saying to me they're going to have to come home. So, that pull factor from elsewhere is going to be gone, but not for good reasons. It's for bad reasons. And I don't think the money there's going to be a huge amount of money to support us in terms of our research career. Having said that, I do think that we've gained a huge amount of research knowledge in Southern Africa, across the African region. When I say Southern Africa, I'm kind of grouping everybody from like from the Sahara downwards. We know how to do research, and we know how to do research at scale and quality research. And I think if we were just more directly turning into a research powerhouse in the region, we've got the laboratory skills, we know how to deal with cohorts, we know how to do human research at scale. If we start doing that better, I think we could take over from huge chunks of the globe and become that powerhouse. But governments do need to start investing in their own people better, and that they need to be doing that. My own government, for instance, we got close to R1 billion a year from the NIH, and that's just gone. South Africa, it seems like Trump doesn't like South Africa for whatever reason, so it's shut that down. But we couldn't even get a meeting with our South African government. They were too busy, with the G20. So, our own government doesn't even think it's important. So it's very difficult. We have to start agitating, I think, for ourselves to make sure that research is actually taken seriously. And that means building research capacity locally and starting to build it regionally. And our politicians need to sit up and listen now, that this is not some luxury that they're promoting. It's something that's important in and of itself, both for the economy, but also for the health of its people.
Excellent there. And just to give you a little bit of a breather, but two quick questions are coming in, and I'll try to combine this. The first is on the aspect that we could probably begin seeing people going to buy their own medicines to care for the HIV or any other infectious agents that they may have. But based on what you're seeing, and we know that the supply chain line, maybe we still have some legacy supplies that are coming through, and whereas the stopping of this funding may have happened differentially from January through now, we may not be feeling the real heat yet. And thanks to some of you guys who are helping with really beginning to look at the future. But when do you see us beginning to see the new infections going up rapidly unabated, the admissions that you were speaking to, and very many of the untoward outcomes? When do we see this happening if we do not do anything now?
I think it's going to start towards the end of the year. I think it depends when the ARVs interruptions happen. When you start interrupting, the people with very low CD4 counts return to those CD4 counts very quickly, usually in a matter of months, and they start getting sick very quickly. The people who are with low CD4 counts when they're supposed to be initiated are not going on to ARVs, and those people are going to get sick and start flooding the hospitals. So I think the rubber's going to, the heat is going to start getting felt towards the end of this year, and it's going to get worse and worse over the next 2 to 3 years. So it's going to be a rocky time just for the near future. Your question about drug supply is a very important one, and it's going to hit us in different ways. The procurement of ARVs across Africa, the three major generic procurers were South Africa, Global Fund, and PEPFAR. But PEPFAR and Global Fund procured the drugs together. So, and South Africa, they were about a third each for the generics. So South Africa did its own thing. So PEPFAR and Global Fund procured 2/3. And because they procured it together, they were able to secure massive supply and volume guarantees, and they got the price down. Now PEPFAR's gone. And with it, Global Fund's, with the major funder for Global Fund was PEPFAR. And while Global Fund's not an insignificant procurer, despite that, it's still not very big. Now, who's going to procure the drugs? Each country is going to have to go and procure from the generics themselves, and that means the prices are almost certainly going to start going up. We're not going to get it down to that $40 a year situation that we had in the past. Also, quality insurement and things like that, which were done through WHO very well for our countries, is probably going to start going down. So there's this, my concern is the prices is starting to first line is going to start going up. The second thing that scares me even more is the small volumes for pediatrics are highly, highly dependent of going through PEPFAR. And they go through PEPFAR and then it gets distributed amongst our countries. So especially the infant formulations are tiny, those volumes. There's very few children that get them. And there's no incentive for these companies to buy those and distribute them to individual countries. So those children are just going to die. There's no way that the company's already saying no one's buying our products, we're going to stop making them. So my fear is that for pediatric formulations, particularly for children under the age of 10 who can't get onto TLD, that there's going to be no options for those children. And essentially with all the pediatric PMTCT children are going to die from now on. So these supply line issues they're not the sexy things people like to talk about. They like to talk about side effects and like all the other stuff. This is the supply lines are where the rubber is going to hit the road and the heat is going to come. And we're going to see the deaths starting to arise from that. And until somebody can just bring the wise heads together to start coordinating that, and I'm hoping that people from the Global Fund and that WHO, and they can sit down and start talking this through. And I hadn't actually thought about this until somebody from the Medicines Patent Pool said to me, because I was complaining about the volumes, and they were saying, watch the pediatrics, because that's where the first deaths are going to come. They're always the canaries in the mine. They're the most vulnerable population who are going to die first. And it's going to be the supply lines that are going to kill them.
Great insights there, Professor Vanta. I have one question from the perspective of our clients. And we know HIV is a chronic condition, and we can speak to only HIV for now. And the aspect that because it's a chronic condition, then the management of our patients, most of it should be happening from the recipient of care side and not from us in the clinical rooms, because we spend 30 minutes with them and then they stay out there for 2-3 months before they get back to us. And if they're not empowered to manage themselves, make some decisions on their own, then the 30 minutes we spend with them will never undo the damage that happens over the 2 months. So what could be your thoughts around supporting the recipients of care to be more forthcoming with their care and treatment practices?
I'm not going to lecture you guys on your individual countries, but I think one thing HIV has taught, I work a lot in diabetes and hypertension and obesity now. But one thing I think HIV has taught us, the more you empower your client, the more you bulletproof them from the system. And certainly in South Africa, when we've had strikes or drug stockouts and things, HIV patients make a plan. When patients in the diabetes clinic, they just fall off their medicines and they wait until things get better. People in the hypertension clinic, they fall off their treatments, their blood pressure goes up. Yeah, I really think that we've learned from the HIV patients and the way the HIV programs is that we need to bulletproof people. We need to like they're the ones. That's where I think the magic ingredient is to try and get them. And then you don't need to spend 30 minutes. You need to just make sure that they understand their treatments. One of my rural teachers, old professor, he said one of the things when he was working in the rural areas, he said the difference between the high blood pressure and diabetes patients and the HIV patients. The HIV patients, he said he'd talk to them in the clinic and they'd say, oh yeah, the virus goes into the cell wall and then it goes into the DNA and then it gets there and the viral load goes down in the blood. And he said he talks to his diabetes patients or his hypertension patients and they say, I've got the high. Nothing else. That's all they could tell him. And he said that was the difference. Like HIV patients knew everything about their disease. The diabetes, HIV, hypertension patients knew nothing. And that I think is such a lesson for all of us as healthcare workers is empower your people because they will be the best way of actually fighting it back when the system starts breaking down.
Thank you very much. I have a question coming in from an anonymous attendee, and she is saying, having worked in the sector for quite some time, he feels that public health system should be redesigned if we are to mitigate against some of the developments in the funding space that we are seeing. What could be some of your comments related to that?
You're talking to my heart here. I completely agree. I actually don't think it's just about the funding space. I think that if you look at primary healthcare sites, even in rich countries, they fail people left, right, and center. And I think that we need to rethink how we develop and how we give primary healthcare out. If you go and look at hypertension and diabetes success rates in rich countries, the wealthiest countries in the world, they fail dismally. So when we don't get our jobs right in Africa, it's not like we're failing because we're poor. It's because the basic tenets of the system and delivery things are not designed well. And I think it's time now to start rethinking how we do this work. Maybe a bricks and mortar clinic is not the right place for this. Johannesburg, it's a big city, it's a middle income country. We've got lots of money in South Africa. And we just been doing these screening programs for hypertension. Hypertension is so easy. You just need a blood pressure cuff. The treatments are easy. The algorithms are well established. The treatments are dirt cheap. And we've got 15% have their blood pressure controlled. Only about 20% have their blood pressure even measured. You have to ask yourself, what's wrong? That's not a training problem. It's not a stupidity problem. It's not a laziness problem. It's a systems problem that I think we need to solve. And I really do think we need creative thinking in terms of this stuff that is way beyond the usual, oh, we just need integration or we just need training. It's so much more than that.
Great, Professor Vanta, and you're by yourself. And so we have about 4 minutes to this closure, but just 2 quick ones. The first is on alternative funding sources, and this attendee is speaking to the medical insurance schemes that are available out there. And his question is, can health insurance, as available in a number of countries in the southern part of Africa, can this be used to support the procurement of ARVs and other services related to HIV care?
Yes, look, I think there are innovative funding models that can do that. And I think they need to be structured. I know Rwanda's got some really interesting models out there. And there are, I remember that suddenly the Dutch model, South Africa's toying with a model, but is not doing it very well, I'm afraid. My country does not have many good lessons to give any of you. But I think that there are models out there that we can look at in terms of private insurance and how they can be done. It doesn't help the poorer countries. I think that health is always going to be, tablets cost a certain amount to actually make. And there are certain countries where it's just basically unaffordable. And I think that there are going to have to be different models for different countries. And it's a bit out of my pay grade, I think, at this stage. So you guys are going to have to teach me about this stuff, and according to your own countries. But certainly, I think there are innovations we are going to have to do. It doesn't solve our immediate crisis, I think, but it is something in the medium to long term that we need to start looking at, is how do we empower people? And I do often think that, if we gave patients money and told them to go and spend their money on the health service that they want, certainly in South Africa, we'd get a much more efficient health service, and not one that, I think the health system suits the patient, the healthcare workers rather than they suit the patient. And if we started handing out the money directly to them, we'd get a very different looking service.
Great, and in the interest of time, we'll hold it there. Very expertly put session and very well done, Professor Vanta from the University of Witwatersrand. You'll have some little time to just give us your closing remarks, but before we do that, colleagues, we will be having the issues around certificates dealt with our back home team, and that will be almost sorted once and once for all. But Professor, again, thank you very much. We need to act and act now. The implication of this funding cut is huge. We may already have started feeling some of them, but there is a lot that awaits us down the road, and we need to really prepare for that. There is so much that we can do with local funding, with alternative funding sources, with strategic decisions from the biomedical science side, from the civil society organization that can help us move our care programs forward, even with these limitations amidst us. So with those, I'll just ask you to give us your closing remarks in about 30 seconds.
So thank you very much, everybody, for your attention. If I got anything wrong or that things have changed dramatically in your country, please let me know, because I'm trying to advocate as hard as possible for the funding to come back, but also just for creative ideas. So please email me, let me know. It's always a delight to hear from the region as well, just what's going on. So thank you very much for your attention and for your time.
Thank you very much. And if there are additional questions coming in through the chat that we have not dealt with, we'll be relaying those to you, and you'll get us the feedback, and we'll make those available to our attendees. Colleagues, time waits for no man. We've come to the top of the hour, and we'll hold it here until our next session. And from us, ASLM, to you, do have the best of your afternoon. evening, wherever you're joining us from.